All right, welcome to The Explainer. Today, we're taking on a really sensitive but absolutely critical topic, deliberate self-harm. We're going to unpack how the International Classification of Diseases, the ICD-10, which is basically the rulebook for clinicians all over the world, how it makes sense of this incredibly complex behavior. So let's just dive right in with the big question that gets to the heart of it all. When you have a behavior that's so deeply personal, so tied to emotional distress, how on earth do you fit that into a standardized medical classification system? Well, the answer is probably not what you're thinking. And this is really the most crucial thing to understand. In the ICD-10, self-harm is not treated as one single standalone diagnosis. You can't just look up one simple label for it, because the system is actually built with a whole lot more nuance than that.
So instead of just slapping on one label, the ICD-10 uses this really sophisticated method called a dual coding approach. Now what that means is looking at the behavior through two very distinct but connected lenses to get the full picture.
Okay, so here's how that breaks down. On one hand, you have self-harm seen as a symptom. That's the why. It's a sign pointing to some kind of underlying condition. Then, on the other hand, it's classified as an act, and that's the what, the specific physical thing that happened. It's a really smart way to separate the psychological root cause from the physical action.
Let's start by looking through that first lens, self-harm as a symptom. Where does this behavior actually show up as a key feature within established mental health disorders?
And what's really striking is just how broad this is. It's not just tied to one condition, not at all. It's a listed feature in a whole range of diagnoses, from depressive episodes and severe stress reactions all the way to emotionally unstable personality disorder. And that just goes to show you how varied the underlying causes can be.
The manual gets incredibly specific here. For example, right there in the official criteria for emotionally unstable personality disorder, it explicitly lists a series of suicidal threats or acts of self-harm. That shows you just how central this behavior is to making that particular diagnosis. And when it comes to severe depression, the link is so strong that the manual, frankly, doesn't mince words. It highlights that the presence of these thoughts or actions points to a distinct danger, which really underscores the immediate clinical risk involved.
So this leads to a pretty logical question, right? If self-harm is the why, if it's the symptom of a disorder, then how do doctors and clinicians record the what? How do they actually document the physical injury itself?
And this is where the second part of that dual coding system comes into play. Clinicians turn to a completely different set of codes from Chapter 20 of the manual, a section that's dedicated entirely to the external causes of injuries.
Right. These are what are known as the X codes. And the key thing to get here is that these codes have nothing to do with why something happened. Their job is just to create a precise, factual record of what caused the injury. They just state what occurred. That's it. And the level of detail is pretty incredible. The codes get very, very specific about the method used. They distinguish between self-poisoning with drugs, harm with a sharp object, or a fall from a high place. And this kind of data is absolutely vital, not just for one person's medical file, but for public health research, for helping to spot trends and shape prevention strategies.
But the system actually goes one step further. It's not just about what's happening right now. The ICD-10 also gives clinicians a way to record a patient's history of self-harm, which is, as you can imagine, absolutely crucial for long-term risk assessment and planning care.
This is done with something called a Z code, specifically Z91.5. You can almost think of it like a permanent flag in the patient's record that just says, hey, this has happened before. It makes sure that a person's full history is captured, providing essential context for any future treatment. So, let's tie this all together. We've got the why, the what, and even the when. So why does this dual coding approach matter so much? Why is it so powerful from a clinical standpoint?
Because it creates this incredibly clear three-part workflow. First, a clinician identifies the primary disorder, that's the why. Then, they code the specific event that happened, that's the what. And finally, they note any relevant past history, that's the when. And when you put those three things together, you build this uniquely complete clinical profile. And that really gets us to the ultimate goal. This whole system isn't just about putting a label on something. It's about building a deep, multifaceted understanding of a person's entire situation, because that complete picture is what truly leads to more effective, personalized care. You know, this whole approach reveals a powerful way of thinking that goes way beyond just medicine. It leaves us with a final question to chew on. In our own lives, how can we use that same kind of disciplined thinking, of separating the why from the what, to better understand the complex challenges and behaviors that we see all around us?